Hello, and welcome to an educational module on the role of continuous perioperative dexmedetomidine infusion to reduce opioid consumption in adult patients undergoing spinal lumbar surgery by Michael Oddie. The learning objectives of this educational module include to demonstrate an understanding of the opioid epidemic in the United States, to identify risk factors for chronic postoperative opioid use in adult patients presenting for spinal lumbar surgery, to explain the mechanism of action of dexmedetomidine, to describe the clinical effects associated with dexmedetomidine, and to identify factors that have prevented dexmedetomidine as an anesthetic adjuvant for patients undergoing lumbar spine surgery. Why is reducing opioid consumption important? Let me briefly discuss some relevant information. Opioids gained attention in the early 1990s and were considered a safe and effective treatment for chronic pain. Their mainstream use was misguided by pharmaceutical company marketing opportunities who supported this movement. The first wave of opioid-related deaths began in the 1990s with prescription opioids. The second wave began in 2010, and the third wave began in 2013 due to an increase in synthetic opioid use, mainly fentanyl. According to the National Institutes of Health, there are 128 opioid-related deaths every day in the U.S. And according to the Centers for Disease Control, there were roughly 500,000 opioid-related deaths reported between 1999 and 2019. Surgery itself is a risk factor for opioid use, especially for the opioid-naive patient. Lumbar spine surgery specifically is a significant risk factor for developing chronic opioid use. Other risk factors include preoperative opioid use, younger age, female sex, history of depression, anxiety, fibromyalgia, and a history of drug abuse, benzodiazepine use, and tobacco use. My educational intervention involves the use of dexmedetomidine for this patient population. Continuous perioperative dexmedetomidine infusion has been shown to decrease perioperative opioid consumption in adults undergoing spinal lumbar surgery. Dexmedetomidine is a highly selective alpha-2 adrenal receptor agonist. It's generally diluted to a final concentration of 4 micrograms per milliliter. It has an onset of less than 5 minutes and peaks between 20 and 30 minutes. Infusion dose range is from 0.2 micrograms to 1 microgram per kilogram per hour. And a bolus dose of 1 microgram per kilogram can be administered over 10 minutes prior to the maintenance rate. So why this drug? Some of the clinical effects of dexmedetomidine include sedation, analgesia, anxiolysis, and sympatholysis without the respiratory depression associated with opioids. Clinical effects are seen after dexmedetomidine binds with all 3 G protein-coupled alpha-2 adrenal receptors. Each of these subtypes have a unique physiologic and pharmacologic function. Receptors are located peripherally, centrally, the autonomic nervous system, in organs, and blood vessels. The spinal cord is a primary site for the analgesic action associated with its use, specifically on the alpha-2A subtype receptor. So why a practice change? Because not all anesthesia providers use dexmedetomidine for spinal lumbar surgeries. The interest lies within the positive outcomes associated with its use while reducing the amount of opioids. Multiple studies have demonstrated the role of dexmedetomidine in reducing opioid consumption. There were 7 studies in the systematic review that included 291 patients. Lumbar procedures included interbody fusion, foraminotomy, and laminotomy with discectomy. Dexmedetomidine was compared to saline as placebo, fentanyl, remifentanil, hydromorphone, piperidine, and morphine. Outcomes included pain scores, perioperative opioid consumption, and length of time to first postoperative analgesia request. Does a loading dose result in better outcomes? 2 studies used a loading dose of 0.5 micrograms per kilogram. Both DEX groups reported less postoperative opioid consumption. 1 study used a loading dose of 0.6 micrograms per kilogram, which resulted in decreased supplemental opioids. 2 studies used a loading dose of 1 microgram per kilogram, which resulted in reduced postoperative opioid consumption. And 2 studies did not use a loading dose and still reported a decrease in intra and postoperative opioid requirement. When should dexmedetomidine be initiated? 4 of the studies initiated Dex during the intraoperative phase, which resulted in decreased intraoperative fentanyl, decreased intra and post-op fentanyl, decreased post-op hydromorphone, and decreased postoperative morphine and time to first post-op morphine request, respectively. 3 of the studies initiated DEX during the preoperative phase, which resulted in decreased post-op meperidine, decreased post-op hydromorphone, and decreased post-op fentanyl, respectively. All studies in the systematic review demonstrate the opioid-sparing benefits of continuous dexmedetomidine infusion. The average infusion rate was 0.485 micrograms per kilogram per hour. There was no difference in outcomes associated with administering a loading dose, as there was no difference between pre- or intra-op dexmedetomidine initiation. Dexmedetomidine demonstrated the ability to reduce opioid requirements in general anesthesia and/or moderate sedation procedures. Anesthesia providers are experts in managing pain and have a pivotal role in addressing the current opioid crisis. Lumbar back surgery is a significant risk factor for opioid exposure. Lumbar surgery generally requires increased opioid requirements. Dexmedetomidine plays an integral role in providing pain control while significantly reducing opioid consumption. What are the factors or considerations that have prevented the use of dexmedetomidine for lumbar spine procedures, and how can you influence change?